Good evening, one and all. So today I'll be presenting on sclerotomies, making and closure under the moderation of Dr. Janani ma'am. Will be the outline of my presentation. So as we all know, vitreoretinal surgery has evolved a long way. So the history dates way back in 1971 when Robert McMahon first used 17 gauge sclerotomies for vitreoretinal surgeries. Thereafter, the vitreoretinal surgery has seen a lot of evolution, and it was the era of minimally invasive vitreous surgery started from around 2004 when ECART along with DORC they made available the commercially available 23 gauge minimally invasive vitreous surgery instrumentations. So moving on to the topic, so starting with the anatomy of the ciliary body. Ciliary body, as we all know, is a part of a uveal tissue, which is triangular in cut section. It consists of two parts. The anterior 2 mm is the pars plica, and the posterior smooth part is the pars plana, which is the area of concern. As ciliary body, it measures 5 to 7 mm in width temporally and 4 to 5 mm nasally. Usually, the pars plana it continues as ora serrata, and we have the vitreous base straddling across the ora serrata. 2 mm of it is in the pars plana region. So, a area of 1 to 1.5 mm is kept as a buffer safe zone, and no incision is placed in this zone. So, ideally, the location of sclerotomy from the surgical limbus it depends upon the age, lens status, and the axial length. So, depending upon the lens status, in phakic eyes, the sclerotomy is made at a 3.5 to 4 mm from the limbus. In aphakic, 3 mm from the limbus, and pseudophakic, 3.5 mm from the limbus. And we'll see how the age and axial length determines placement of the sclerotomy. So in standard three-port pars plana vitrectomy, we have two superior port and one inferior port. The superior ports are the active ports through which the actual manipulation is done, and the inferior port is the passive port. Usually, it occupies the infusion cannula. So why is this arrangement made? Why two superior, one inferior? Because we it prevents it allows good maneuvering during the surgery, and it prevent interference of this passive cannula during the instrumentation. So first the inferior sclerotomy, which is the first sclerotomy to be placed. It usually occupies the inferior-temporal quadrant. Usually it is generally placed below the horizontal meridia. Avoid placing it too horizontally and too inferiorly. Placing it too horizontally can damage long ciliary neurovascular bundle, while placing it too inferiorly can result in uh, knocking of the cannula against the wire speculum, then kinking of the infusion tube, and hindrance with the globe rotation during the surgery. The superior sclerotomy, two superior sclerotomies in the supranasal quadrant and supratemporal quadrant. They are usually placed 150-degree apart to each other. The supranasal sclerotomy is placed along an imaginary line extending from the base of nose to the center of pupil, while the supratemporal is placed from lower part of superior orbital rim to the center of pupil along the imaginary line. Always the angle of 150 degrees to be maintained. So in any special situation, you need to shift any of this sclerotomy. Simultaneously, you need to shift the other superior sclerotomy so as to maintain this angle. Now, why is this angle important? If the superior sclerotomies are placed too closer, it makes it difficult in holding the two instruments together closer. There is a difficulty in peripheral vitrectomy and rotation of the globe. So, how should be an ideal sclerotomy incision? It should be simple to construct, facilitate easy maneuvers, maintain integrity in postoperative period, prevent egress of intraocular contents and ingress of extraocular materials. So, there are different incisions for sclerotomy like uniplanar, oblique, and biplanar. A uniplanar incision is made at a 90-degree perpendicular to the sclera. As shown in this schematic diagram, this is highly unstable incision because the pressure exerted from any side of the wound can result in opening of the wound, making the wound unstable. Second, this is not a self-sealing, needs closure, good closure. Second is the oblique incision, also known as Zorro's incision, in which the incision is placed at around 10-degree inclination to the sclera. Then we have the biplanar incision, which is the most preferred and commonly used technique nowadays. So, talking about biplanar incision, the basic technique is to insert the trocar cannula at an angle of 45-degree to the sclera for 50% thickness of the sclera, or clinically you can insert it till the microcannula area is reached. Then you rotate it and insert it perpendicularly, so it results in making a biplanar. But in minimally invasive vitreous MIVS era, it aims at a small wound size and self-sealing wound. So how does this biplanar incision fulfill this criteria? So the basic aim of a self-sealing wound is a small size of wound, which is fulfilled by use of smaller gauge instruments. Then multiplanar nature of the wound, which is fulfilled by this biplanar nature, and a disparity in the internal and external uh, wound, which is made by retracting the conjunctiva. So there is disparity in the conjunctival and scleral wound. The sclerotomy wound can be circumferential and radial. The circumferential wound, the scleral entry incision is parallel to limbus, and the intrascleral tunnel is radial. And this wound are in line with the scleral fibers, whereas the radial wounds, the scleral entry is perpendicular to the limbus. They cut across the scleral fibers. The most preferred is the circumferential. Why? Because if there is excessive stretching of this wound during the surgery, longer duration of surgery, the stretching occurs parallel to the limbus. Whereas in cases of radial wound, if there is excessive stretching, the stretching goes towards the limbus, and it can result in some dreadful complication intraoperatively, can damage the root of iris and can cause intraocular hemorrhages. So, talking about the biplanar, we'll see the biplanar incision. The first step is to for adequate globe exposure, which is made by use of self-retaining stout speculums. Second important step is the measurement of distance from the limbus. So, various instruments are available, like the Castrovijo's caliper, Bronstein's caliper, but the most commonly used nowadays is the trocar cannula system mounted calipers. The trocar cannula system, as seen in this video, it has to measurements the 3 mm and the 4 mm marks on the one end of the trocar cannula. So how do we measure? So we place the edge of the trocar cannula over the desired quadrant, exert a gentle and firm pressure so as to indent without deforming the globe. The second important step is conjunctival retraction. Why is this step important? Because this helps in disparity in the conjunctival and scleral incision. What is the significance? It helps in making it self-sealing. It avoids exposure of the scleral wound to the conjunctival contaminated flora or tear film. Then also it helps in micro wound leaks, sealing of the micro wound leaks. Also it prevents, seals the vitreous weak in the subconjunctival space. So we can retract the conjunctiva by using LIMS forceps, Colibri forceps, or even cotton tip applicator can be used. So retracting the conjunctiva, you usually pull the fornacial conjunctiva toward the limbal end. I usually hold it anterior to the point of insertion. Holding it posteriorly results in exertion of undue pressure, can result in tearing of the conjunctiva, and especially importance in old age group because the conjunctiva is fragile. There are some specialized instruments called the pressure plates which serve the multi-purpose use. They can be used for measuring the distance from the limbus, and it for retraction of the conjunctiva and stabilize the globe. So all in one function can be made with the use of these pressure plates. So now the next step is to make the sclerotomy incision. So for incision making, the basic we need to know about the trocar cannula system. So trocar needle plus micro cannula and trocar handle consist of trocar cannula system. And this trocar cannula system plus cannula plug plus infusion line consists of entry site alignment system. So why is the need to have such kind of system? It basically helps to align the conjunctival and scleral incision. It allows easy instrumentation, allows easy passage and removal of the instrumentation. It prevents excess stress on the vitreous base. So the trocar cannula system, they are available in different sizes. They are color coded. Uh, the orange and blue color and the pink color. The size is, the more the number, the lesser is the outer diameter. We have the 20 gauge MVR blade with the outer diameter of 0.89 mm to the recent 27 gauge with the outer diameter of 0.4 mm. To the trocar blade, the H plus blade developed by the Alcon Laboratories is the most commonly used trocar blade. It consists of three parts: the leading edge, ridge, and the trailing edge. The leading edge and the trailing edge are the cutting edge, while the ridge is the stretching point. Secondly, after the trocar, the important thing is cannula. The cannula are available in different length, different material. They can be walled and non-walled. The usually used cannula is the 4 mm. 6 mm cannula can be used in some special situations, like in case of thickened choroid or choroidal detachment, suprachoroidal hemorrhages. You This length, it denotes the length of the cannula itself in MIVS era, whereas in 20 gauge era, if you have only the infusion, so if you change the infusion length, cannula length will change, whereas in MIVS only the cannula length will change, not the infusion length. So they are available in different material. They can be disposable, polyamide, single use, or can be stainless steel and titanium, which can be reusable. So cannulas are walled and non-walled. So non-walled cannulas are just basically a open system where there is a continuous leakage of wound. There is a extrusion of the or incarceration of the vitreous in the wound during instrumentation removal. So small video demonstrating how the non-walled cannulas after removal of the instrument is the pulling of the retina towards it, and highly turbulent environment, unstable fluidics, making it unfavorable for operation. Whereas in case of walled cannulas, as you can see, there is a stable fluidics, IOP is maintained, no turbulence, so providing a adequate good environment for operation. The walls can be in form of a cap, silicone cap, or it can be for in form of silicone membrane. So always follow a checklist before uh, insertion of the trocar cannula. Always check for the tip of the trocar, whether it is sharp, blunt, or bent. Now, why is this important? To look for the sharpness and blunt, whether it is blunt. It's just the basic physics behind it is the sharpness is directly proportional to the uh, basic physics is the we need to, for any puncture we need to exert a pressure. This pressure is proportional to the tissue which we are puncturing. To achieve this pressure we need to exert a force, and this force is directly proportional to the sharpness. So sharper the trocar, lesser will be the force needed, and so lesser distortion of the wound. And while in case of bent and blunt tip, it result in formation of a ragged wound, which does not follow the self-sealing principle and needs a wound closure. Secondly, check for presence of cannula on trocar, and thirdly, free movement of cannula on trocar. This is how the trocar has a micro cannula mounted on it. It should be freely mobile over the trocar. So now, what should be the direction of the sclerotomy? Usually 6 and 12 o'clock meridia are the reference point for the direction of sclerotomy. Majority of the surgeries are performed from the superior active ports, and they are directed toward the inferior pole. So any sclerotomy made in this direction will result in less distortion of wound, easy handling of the can easy handling and good rotation of the cannulas. Whereas if the sclerotomies are directed toward 12 o'clock, it results in twisting motion of the wound, causing distortion, unstable wound, and needs wound closure. So to sum up all these steps, the video showing how a biplanar incision is made, retraction of the conjunctiva followed by oblique entry and then the perpendicular entry. Though the 20 gauge era, 20 gauge system is not used nowadays, just highlighting points regarding the 20 gauge, in which we use a MVR 20 gauge blade, and a uniplanar incision is made directly perpendicular, and then the sutures are placed to hold the infusion cannula. Nowadays, 20 gauge system is used in cases of post trauma cases, intraocular foreign body cases, or in retained lens fragment while using phaco-fragmentum. So there are some special situation that can arise while insertion of the trocar. The angle of insertion can be shallow. What this does is the blade does not penetrate into the eye; it remains intrasclerally throughout. If the angle of insertion is steeper, the wound size is less, resulting in unstable wound. If the and avoid inserting the instrument too far, it can damage the internal structures. The sclerotomies in now we'll see the sclerotomy in special situation. Before moving on with this, there are few special situation like post trauma cases, myopia, SFIOL. The all this special situation needs a good preoperative evaluation, may it be in form of history taking, anterior segment evaluation, or investigational evaluation, so as to plan the surgical procedure adequately. So, firstly, the post-trauma case. In case of the post-trauma, always avoid the areas of scleral laceration, avoid the areas of retinal incarceration. As seen in this image, the this is a status post sclerocorneal tear repair. Whole the inferior quadrant has had the sclerocorneal tear, so there is no space for the infusion cannula. So, modification, the infusion cannula is placed at 12 o'clock. In cases of choroidal detachment, suprachoroidal hemorrhage, always avoid the areas of suspected detachment or with the areas of suprachoroidal hemorrhages. One can use a 6 large cannulas. In cases of SFIOL, you need you need a space for scleral flaps and scleral tunnels at 3 and 9 o'clock. You need 7 to 8 area superiorly to accommodate the rigid SFIOL. So you need to shift the sclerotomies accordingly. The infusion cannula or the inferior sclerotomy should be shifted more inferiorly, and the superior sclerotomies should be shifted superiorly. In case of high myopia, what problems do we face are the thin sclera, the wider pars plana, long axial length, the vitreous plugging the wound is less efficient because of liquefaction, and the pressure on the sclera exerted by operator during the procedure in order to reach the posterior pole could undermine the wound sealing. So what are the modifications done? Wound architecture should be biplanar. It should be parallel to the limbus. Move sclerotomy plane more in the horizontal meridian more posteriorly. Avoid 25 gauge and 27 gauge. And one can also use the sclerotomy directly without placing the cannula hub. This provides a 2 additional length to reach the in cases of high myopia, and suture the wound, as high myopia is a indication itself for wound leakage. In previously operated eye, in 20 gauge era, the sclerotomy port within 5 to 7 days of the previous surgery could be opened by removing the sutures, and same port can be used. Whereas in MIBS, there is higher chance of leak if previous sclerotomy site is used. Usually, it is difficult to find the previous sclerotomy site due to the smaller size, and making another sclerotomy 2 to 3 adjacent to it remains self-sealing. So schematic representation. So first image shows the first operation. During the second operation, you place the incisions adjacent to the first site, and as on if the surgeries are needed, you make the incisions. But what happens with each surgery, with healing of this wound, they result in coalesce of this wound and making this sclera papery thin. So with further surgeries, there is high chance of wound leak, high chance of non-closure of the wound, even with good closure. So one can prefer a radial incision in such kind of situations. In pediatric eye, the eye grows to 85% of its axial length by age of 2 years, and it grows to uh, it continues to grow. So the challenges with pediatric sclerotomies are the thin sclera, high scleral elasticity, variable pars plana, and then usually the lens occupies the larger portion of the posterior segment and short intrascleral path of the cannula. So, in the pediatric age group, in a term baby with age less than 1 year, the sclerotomy are made at a distance of 1 mm from the limbus, 1 to 2 year at 2 mm from the limbus, and usually after 3 year, 3 mm from the limbus, and thereafter 3 to 3.5. In cases of premature infants, it is sclerotomy is placed 0.5 mm posterior to the limbus. A video showing the pediatric sclerotomy making. The infusion cannula with the chandelier has been used here to make the infratemporal sclerotomy. So now moving on to the closure of sclerotomy. Always close the superior sclerotomies first and the inferior sclerotomy last. This helps in controlling the IOP. Ensure good vitrectomy done around the port size before removal of the cannulas. As the cannula is a hollow tube, the negative pressure inside can result in traction over the vitreous base and incarceration of the vitreous. So therefore it is preferred to remove the cannula after plugging it by use of either light ply or a plug. So what are the mechanisms causing the sclerotomy wound closure? The two mechanisms act at the wound site. One is the mechanical collapse of the tunnel, and second is the surface tension of the intraocular vitreous replacement. Mechanical collapse of the tunnel is achieved by applying a firm pressure over the anterior lip of sclerotomy with solid instrument for about 1 minute. It results in opposition of the roof and floor of the wound and regaining of the elastic memory of the scleral fibers. Secondly, the surface tension of the intraocular vitreous replacement. If the surface tension of the vitreous substitute exceeds IOP acting at the sclerotomy site, it remains as a single bubble and withstands leaking. So commonly used tamponade gas has a higher surface tension as compared to oil and BSS. The silicone oil has the lowest surface tension, so has higher chance of leak and it needs wound closure. The closure of sclerotomy wound. In 20 gauge wound, you one need to, if the conjunctiva is open, directly a scleral wound is sutured with 6070 vicryl suture. If the conjunctiva is not open, limited peritomy is done and the wound is sutured. In 20, in the MIVS era, usually the incision, if constructed well, the architecture is good, it results in self-sealing incision. A video showing how the self-sealing incision work. A 20 gauge cannula are removed, and remember to remove the cannula in the same direction as they were inserted, and a firm pressure is applied over the area so as to create a self-sealing. But if the self-sealing nature of the wound fails and one needs to close the wound, what are the options available? First is the suturing of the sclerotomy wound, usually done with the help of 607080 vicryl. The 60 vicryl was commonly used in 20 gauge system. With nowadays 7080 is preferred absorbable sutures as the instrument used for the closure. Now the different suturing technique available to close the sclerotomies are simple interrupted suture, schematic diagram showing a circumferential incision. If a single interrupted suture is to be placed, a partial thickness scleral bite is taken at the center of the wound and it is tied, knot is tied. Secondly, the shoelace suture, commonly preferred. A schematic diagram representing how to take shoelace suture. Firstly, the superior sclerotomies are closed, so a partial thickness bite is taken adjacent to the cannula or wound. Then the exited needle is taken to the opposite side of the cannula. And again, a partial thickness bite is taken adjacent, and then the two ends are tied, making it a shoelace or a X. Likewise, other sclerotomies are closed. The video showing the shoelace suture. Partial thickness bite is taken, the same needle is taken to the adjacent side, and then the two ends are tied. We also have a mattress suture. This is how a mattress suture is placed. The other techniques that can be used are the cauterization of sclerotomy size. Use of a bipolar cautery has been done, but this results in scleral shrinkage, scleral fibrosis, and if this cauterization fails, then it is difficult to even suture the such kind of sites. Tissue glues and polyethylene glycol based hydrogel bandages have been used for sclerotomy closure, but due to higher cost, usually not used. Intrascleral hydration of the sclerotomy closure. It works on the same principle of the cataract surgery. Hydration of the sclerotomy is done with BSS, result in swelling of the scleral fibers and causing closure. So, what are the complications of sclerotomy? Sclerotomy has several intraoperative, early postoperative, late postoperative. So, starting with the transient IOP rise, during a sclerotomy trocar insertion, there occurs a transient IOP rise, which can result in opening of the recently operated corneal or scleral wound. So, it is advisable to suture the recently operated scleral or corneal wound before trocar cannula placement. And if excess pressure is required, then use a twisting or wriggling uh, technique to insert the cannula. Second is the cannula retraction. Intraoperative retraction of cannula is known to occur, and it can lead to several complications. If the infusion cannula is retracted and it goes unnoticed, can result in choroidal detachment. Usually in dark environment, cannula retraction goes unnoticed, so one should have a habit to intermittently have a look at the cannulas. Why does this occur? This occurs because of using small size of cannula. It can occur during scleral indentation, during resurgery post-trauma cases, and re-sterilize cannulas. The cannula can get misplaced because of retraction. It can go into suprachoroidal or subretinal space. If the cannula is in suprachoroidal space, uh, we need to insert a needle through the same cannula and make the opening. We can insert through the same site with a larger size cannula, or we can make a new port. So, if a light pipe is passed through a cannula and we get a bright white glow, it suggests that we are in the vitreous cavity. If we get a dull reddish brown glow, it gives a suspicions of we are in the suprachoroidal space. So, if in case this goes unnoticed and suprachoroidal fluid is there, then immediately close the infusion, pull out the infusion line, put it through the another cannula, and check its positioning before starting. Drain the suprachoroidal fluid through the first side. Then enlarge. If the tab goes dry, then we can enlarge the sclerotomy site and then suture the sclerotomy. Wound leak. This video shows the wound leak. Usually, wound leak is likely to occur in some of the cases, so one need to predict it before only that and plan accordingly for regarding the wound closure. So, such situations are high myope post-trauma cases, post-sclerotic cases, when there is extensive vitreous-based dissection, longer duration of surgery, then the lens touch can occur during placement of the trocar, improper placement, more anterior placement, or also rotation of the cannula or trocar anteriorly can result in lens touch. Retinal break formation is also more posterior placement of the trocar. During globe rotation, it can damage the retina, and also during the wound healing stage of the sclerotomy, if any vitreous weak is get stuck in the intrascleral tunnel. With the healing, they result in the contraction of the vitreous weak, causing retinal break formation. The endophthalmitis, this is the dreadful complication. The reason for a sclerotomy related endophthalmitis is the entry of organism from ocular surface into the eye due to wound gap. Post of hypotony may provide a suction force to draw the surface organisms. Incarcerated vitreous at the wound may act as a wick for bacteria. So to conclude, those simple step, it is a keystone of MIVS surgery. So understanding the proper wound architecture and construction is essential for safety and success of this surgery. My acknowledgements. Thank you.
Thank you, Saurav. It was a very nice presentation, very elaborate, nice videos. So, any doubts anybody has? Yes, sir. Please, sir.
Okay, so a couple of things only. Sort of excellent presentation. And if people will think like sclerotomy, what is the big deal? How can you talk so long for a sclerotomy? Yes, I think it's very nicely covered, everything very well done. So, like just some practical issues here. So yes, you need to measure exactly 3 millimeter or 4 millimeter, whatever you want to. But I would suggest displace conjunctiva first, then measure, and then get the blade inside. Because suppose you measure first and then pull the conjunctiva, sometime then you may miss your marking. Okay. So always what happen your forceps generally or whatever device you are suggested showed too many devices, they help you not only to displace the conjunctiva, stabilize the globe as well. So when you hold with the forceps, generally not only conjunctivas, like a episcleral tissue also we hold after displacing, so that globe gets stabilized, conjunctiva is displaced, and when then you just check most of the times, as you rightly mentioned, back of the your trocar cannula blade handle, measure and then enter inside. So then you exactly know your blood vessel marking, all those things that where you are going in. That is one. Okay, second thing is when you enter the blade, yes, you are rightly mentioned whether it should be whether it should be parallel to the limbus, whether it should be uh, perpendicular to the limbus. I agree that if you have a radial sclerotomy, extension can go anteriorly towards the lens and posteriorly towards the retina if sclerotomy enlarges. Generally, that is not the issue most of the time when you're doing with the trocar cannula system. That used to be a problem with 20 gauge, and that's why invariably with 20 gauge we used to make a circumferential sclerotomy or sclerotomies parallel to the limbus, not radial. Now the issue here is if you go circumferentially, the way your direction of blade going oblique from almost superior to inferior and then turning in, what happened? Your track will not be like a wall; it not be self-sealing, because you just need to imagine here. Particularly second incision, what you showed three incision. One is straight perpendicular. The second one was oblique. When you are oblique, what happened when you have pressure from inside or outside in or inside out? So when it is oblique cut, the two surfaces approximate each other, and that makes the section self-sealing, particularly when you have positive pressure inside. But if you go what you said is circumferential, the way it is cutting through, your incision line is circumferential, but your angle where the blade enters in is a different angle, oblique. So, so it will not be self-sealing. Track keeps on leaking. So when you make a trocar cannula system you are using and you expect it self-sealing, most of the time your sclerotomy, when you probably all of you are doing, you look at watch yourself now what you are doing. You are going, blade is placed radial to the limbus, perpendicular to the limbus and not parallel to the limbus. And that gives you much better and more likely that your sclerotomy will be self-sealing. And third and most important thing is you need to have a positive pressure inside, and that is what, yes, like a cataract section also, unless you have positive pressure, because pressure has to build from inside out, then only sclerotomies will be self-sealing. The tendency we said, okay, no, let me reduce the IOP little bit. No, in fact, when IOP is less, when the tissues get distorted, again section will not be self-sealing. So ensure little bit positive pressure. I won't say like 35, 40, but generally around 30 pressure should be okay. Little bit more between 30 and 35 should be okay when you close the sclerotomies. Of course, silicone oil issue is different. I am not discussing here that part. They are invariably we suture the sclerotomies. Okay, thank you very much. I think I am clear.
Yes, sir.
Yeah. No, otherwise, excellent presentation.
Anybody else have any comments?
You ask fellows whether they have any doubts.
Sure, sir. So all of your sclerotomies are perfect.
All are experts now.
See, I would like to insist in planning. So, whatever it's the case, preoperative planning. That is the most important thing for a successful sclerotomy. And don't be hesitant in suturing. We though aim at self-healing sclerotomies, especially diabetics, especially people nowadays wear masks, not very hygienic. So please be don't hesitant in sclerotomies. All oil-filled eyes, please suture the sclerotomies. And sometimes what happens, we to take a shoelace, still you find it little bit leaky. So don't put another suture over it. That's what most commonly sister says. Please don't do it. Cut the suture. If you want, please open the conjunctiva, see the opening, and do the suturing properly for a good sleep. And infusion sclerotomy, always take the sutures. And other thing what I want to insist is gas filled eye. When we do the gas injection, we'll close one sclerotomy. Please take pre-placed sutures for the other sclerotomies as well, and then do the gas injection. Gas doesn't give time for, like how even in a oil filled eye, even if you're not able to close, if it's leaking, it gives time, but gas doesn't. It quickly, the globe can collapse, especially in one-eyed patient, high myopes. When you doing gas injection, please take pre-placed sutures for the other two sclerotomies. And in cases of no view, a good ultrasound should tell us exactly where is the any choroidal detachment or any other lesion which you anticipate adjacent to the likely sclerotomies like ITQ. Specifically look in ITQ. And those who do ultrasound also, please, if you see anything that can affect sclerotomy location, do mention with the quadrant. And all the cases of retinal detachment with the view, I request all of you to see once before blocking as well as after blocking and rule out pars plana detachment. Though it looks simple, it is the most important step because it's the fulcrum where we operate. When we are not happy with the sclerotomy, the entire surgery can be painful. And more commonly, when you withdraw the instrument, the cannula can come along, and that is a very common thing what we see. Please do change the cannula. And when we insert, instead of going with the instrument, better to go with the trocar, put the cannula again and then go with the instrument. Every time you go inside and come out, we are handling the meddling with the vitreous around the sclerotomy site.
Yeah, Janani, one more point. Just now, what you said.
Yes, sir.
Just for a sake of everybody feel like we need to go want the self-sealing sclerotomy, so should not be like go too much of oblique. Otherwise, your entry and exit wound can be somewhere else, and sometimes you can remain in a suprachoroidal space also. So that enthusiasm that I want to be oblique, that's one problem. Another problem is too oblique, then movement of the instrument also get restricted in the eye.
There are no other comments. Can we call it a day? GSI, ma'am, senior
Hi,
resident.
Janani. It was a very nice class.
Yes, ma'am.
Only one single point what I wanted to add was, see, every surgeon has a kind of a working distance, the angulation.
Yes, ma'am.
So sometimes that superior two ports are so important that if the angulation of the person who made the sclerotomy and the surgeon who will be performing this sclerotomy, if it is a prolonged surgery, for a short time surgery it may not actually have any effect. But if it's a prolonged surgery, if you have a very worst PDR and all, you have to be very comfortable with the superior two ports. So you will
Yes, ma'am.
have to make it at that angle at which you are very comfortable. Otherwise, what would probably happen in a prolonged surgery is your wrist will get unsupported and very high possibility of having tennis elbow, those kind of things will be there.
Yes,
When
ma'am.
you are planning, to do for a long time surgery. Apart from that, I have nothing else to add. It was an excellent class.
Thank you, ma'am. The most important take-home messages before performing the sclerotomy, see the tip under the microscope. Sister will say it is new, it may not be. Please see the tip under the microscope. Thank you, everyone.
Thank you very much.
Thank you, sir.